Better by the Numbers podcast. Presented by Life Metrics.
All right, guys, welcome to another episode of the Better by the Numbers podcast, where we are exploring how doctors are using lab testing in smarter, more forward-thinking ways and to transform patient care. I'm Aaron, your host, and in each episode, we talk about practitioners across the country who are pushing medicine forward through data. Today, I'm joined with Dr. Bhavana Bhatnagar, an associate professor of medicine at West Virginia University Cancer Institute. She's a board-certified hematologist and oncologist with a background at institutions like the Cleveland Clinic and Ohio State University. And her work focuses on hematologic cancers and improving outcomes for underserved populations. Dr. Bhatnagar also leads research on disparities in cancer care with publications in journals like the New England Journal of Medicine, the Journal of American Medical Association, and she has received multiple teaching and patient satisfaction awards. Dr. Bhatnagar, thank you so much for being here. It's great to have you. Can you tell us a little bit about your background and your journey to medicine that got you where you are here today?
Thank you so much for having me and trying to get my perspective on moving the data forward. I grew up in Pittsburgh, Pennsylvania, and lived in just a suburb there. My mom is actually a physician herself, and so most of my early childhood experiences were in some way related to growing up in a home where one of my parents was a physician. And so I got a chance to see how she cared for patients, and I learned a lot of medical terminology, mostly through osmosis and hearing her talk to consultants or the hospital over the phone. And I really looked up to my mom and really wanted to do medicine. I was inspired to go into the field of hematology, oncology early in my life. Mostly, it wasn't that I had any major personal experiences with it, but I was one of those strange kids who would be glued to these human interest stories that were airing on TV shows like 2020, where they would oftentimes feature a family that was undergoing a cancer battle. And as a kid, I remember being emotionally drawn to those stories and thinking to myself that I really wanted to help those people one day when I got older. I had a few personal experiences too when some friends that I grew up with had more personal experiences with cancer, and I remember being kind of on the outside feeling like I wanted to help, but I really didn't believe that I didn't have the skills or the expertise to do much in that situation. So I figured that I would get the skills and the expertise and ultimately help patients and their families who were struggling with cancer. Those experiences were deepened throughout medical school, residency, training when I started taking care of patients with acute leukemia. And that patient population, the blood cancer population, really resonated with me. Patients with acute leukemia in particular are unique compared to patients who have other types of cancers in the sense that when they're diagnosed, the treatment is really urgent and they spend a lot of time in the hospital. And when I say a lot of time, I mean like weeks, months, and you as the resident or the trainee get to know them and their families extremely well. And it was the intensity of those relationships and knowing that there really is an art to being able to navigate all of that really drew me further into the field. And then I had a lot of research experiences too with some of my mentors at the Cleveland Clinic and the University of Maryland and Ohio State University, and now where I currently work at West Virginia University Cancer Institute within the AML space and other acute leukemias that really has sustained my interest over time.
Wow. Yeah, that's actually really inspiring. I love that you said that you saw it happening like as a kid and you even watched all these shows and it inspired you to want to like help. And didn't realize that those specific types of cancers are like so urgent. Like you said, there's like an art to it. You have to attack it like head on. They're spending so much time in there that like it can be like a big sudden change of life, like immediately, and it's just, especially when you get diagnosed and you just have to do all these things. You have to change your routine. You have to, like your lifestyle is like completely upside down at that moment.
Oh,
I can't even imagine. So,
without
yeah.
question. mean, a cancer diagnosis will turn any patient's life on its head. The blood cancers are, like I said, different in some respects, especially the acute leukemias, because when those people are diagnosed, their treatment needs to start right away, and it does involve an inpatient hospital stay for many patients, whereas a lot of people with other types of cancers, breast, colon, lung, are oftentimes stable enough to receive their treatment in the clinic side. And so, it's just a different way of managing each of those diseases, but just the sheer intensity of emotions and testing and everything that happens when you're telling someone that they have cancer, I think, it takes, I would say, a different kind of person to be drawn to that and to want to navigate people through their diagnosis successfully, both from a treatment standpoint, but also emotionally, and also to take care of their family members, because cancer never affects the person alone. It always affects their entire support system.
Right. Right.
And so you as the physician do need to be prepared to handle that also.
Wow. It's like a lot of psychological things going on in that moment as well, because you're also breaking it down to the family, and so you mentioned testing. Every doctor, I would say, has a test that stands out. What's one that kind of shaped a decision or even a career path or a life, like, that changed the course of things for you personally, and what made it so impactful?
Yeah, I'm glad you asked me that question. So the disease that I've spent a lot of time working on throughout my career is acute myeloid leukemia, and also known as AML. And it's a relatively rare blood cancer, but it is a very devastating one. And the first time I started even interacting with patients who had AML was when I was in medical school. And as I mentioned earlier, these patients were often admitted to the hospital during my inpatient rotations, and I would spend the entire month with people from the time they came in through the emergency room or from clinic until they got all of their chemotherapy. And at the time when I was in medical school, there was so little that you could offer these patients. So they either got this 4 to 6 week long chemotherapy, this regimen that it itself is not 4 to 6 weeks long, but they are admitted for 4 to 6 weeks to try to get their leukemia under control. And if you weren't able to tolerate that really intensive regimen, there wasn't a whole lot in the way of lower intensity chemotherapy treatment options that were available. And then there was also around that time the recognition that not all AML is created equally from a biological standpoint. So some leukemias look different when you really drill down into the genetics of the leukemia cells themselves. So around that time when I was in medical school, cytogenetics or chromosome testing was starting to be used more frequently, and you could basically analyze the leukemia cells for the presence of certain chromosomal abnormalities, and those chromosomal abnormalities would tell the physician how aggressive someone's disease was likely to behave. So there are some chromosome changes that are actually considered favorable risk and predict for a good response to chemotherapy, and then there are other chromosome abnormalities that predict for a much more aggressive course. And we know from the get-go that this person's AML might be more difficult to cure than someone else's, and it also directs us a lot in terms of which patients need a stem cell transplant. So really, initially, it was those chromosomal changes. About 50% of patients who have AML have normal chromosomes, and when you look at this group of patients, the ones who have no chromosomal abnormalities in their leukemia cells, their survival outcomes are highly variable. So some of them do really well and some of them do really poorly. So then the AML community started drilling down beyond the chromosomes and looking at certain mutational testing or molecular testing, next generation sequencing essentially, to look for gene mutations that could be helpful in terms of prognosticating how well these patients were going to do. And so after the chromosomal changes, we started drilling drilling down into the genetics of the leukemia cells themselves. And so we were able to search for recurring mutations in common genes like FLT3 or NPM1. And so all of those gene mutations told us, again, how a patient's leukemia was likely to behave. And later on, these gene mutations were able to pave the way for therapy. So now we have pills that we can use to treat AML patients who have certain types of gene mutations. So we have FLT3 inhibitors, we have IDH1 and IDH2 inhibitors. We have a newer class of agents called menin inhibitors that target patients who have KMT2A rearranged AML or NPM1 mutated AML. And so compared to when I was in medical school, when everybody just got the same treatment, we are able to offer more personalized care delivery on the basis of the biology of somebody's leukemia, which is amazing and honestly has sort of trickled down, I think, into the oncology space as well. But really it all started in the hematology space when
Right.
the oncology piece. And so it's really nice that nowadays my conversations with patients who have AML, I have more things to offer them that hopefully extend their life. I mean, I would love to be able to save more people. Outcomes are improving overall, but I think all of us who take care of patients with those diseases want to see more cures.
Right. Wow. That's a long way to go from what you said when you started in medical school to now. Like everything is a lot more personalized, and you can even tell them how how they're going to react to the treatment or how well the treatment is going to go. That's huge. That's actually really huge. So you mentioned a little bit of like, I guess, testing and genetics. So at like, what was the biggest, I guess, turning point in the lab testing that started to play a bigger role when in your work? What was when did that happen?
It happened like during my career, which honestly hasn't really been that long. but
Gotcha.
but I would say maybe like 10 years or so ago, 10 to 15 years ago is when next generation sequencing testing became a standard part of diagnosis for AML. And so this allows us to run the leukemic blasts on a next generation sequencing panel and allows us to search for the presence of certain mutations that help us do two things. They help us prognosticate, and they also help us with treatment selection, including whether or not somebody may need a stem cell transplant later on down the line. And so these next generation sequencing tests are supposed to be done at the time of diagnosis, and they are also supposed to be done when patients progress or relapse. So we do know that AML is not a static disease, so it does evolve over time, and certain gene mutations that might not have been present at the time of diagnosis can grow out over the course of therapy through a process of clonal evolution. And so I think that the NGS testing, at least for me personally, has been the biggest breakthrough.
Wow. Now, you kind of touched on this a little bit, but I'm going to ask you to kind of walk us through a case with no names, no patients, of course, where testing results made a really big difference in treatment and outcome.
Yeah, so one that really resonated with me is a patient I took care of several years ago who was in his 70s and was admitted to the hospital with a really high white blood cell count and a heart attack. And so two big issues going on at the same time. And so we were trying to figure out, he was ultimately diagnosed with acute myeloid leukemia, and he had a lot of other medical problems that would have made it difficult for us to treat him with intensive chemotherapy. He was also freshly struggling with a significant myocardial infarction or a heart attack. And so we were waiting for him to be more stable from a cardiac standpoint. We were able to sort of control his disease with a medication called hydroxyurea, which at least sort of can be helpful in controlling the blood counts when they're really high. Probably about a week into his stay, his testing came back showing that he had a mutation in a gene called FLT3. More specifically, it was an internal tandem duplication, so there was a segment of the gene that was like repeatedly duplicated, and FLT3 ITD mutations happen in about 30% of people who have AML. And so right around the time that this gentleman was diagnosed, there was a FLT3 inhibitor that had recently gotten approved by the U.S. Food and Drug Administration. And we were able to use his molecular testing to justify getting the drug approved. And all he got was that pill to manage his AML. And he was in remission for 3 years. And so which is almost unheard of, because quite honestly, like, I think if we had given him more intensive chemotherapy, I'm not sure that he would have survived that. That would have been a very risky thing to do. But he was able to achieve a remission within a month, and he stayed in remission for at least 3 years. I had actually left the institution by the time he was still in remission, so I'm not sure how he's doing right now, but that example really stood out to me. Because he was able to live so much longer than what we thought and have a really good quality of life. I had another gentleman who carried a diagnosis of a really unusual type of leukemia, which we thought was acute lymphoblastic leukemia, and I remember when I met this patient and their family, they were just in tears because they had seen another oncologist before me who had basically suggested that this patient go on hospice. And we discovered when we were doing the next generation sequencing testing that he had a mutation in a gene called IDH1 at some point during his disease course, and he was able to achieve a remission on that, and he lived 5 years following his diagnosis. And I remember his family telling me that, even though we didn't cure him, even though he wasn't able to, survive past those 5 years, they were grateful for the time that he got, because he was originally quoted a diagnosis, a life expectancy of 6 months, and they were able to make some important relationship fixes, for lack of a better term. So he was able to reconcile with many family members and sort of leave this earth more at peace, and had more of an opportunity to do some of the things that he wanted to do. And for me, that was a huge win.
Yeah, no, it is a huge win. It's actually very poetic to be able to get back to your family and actually, think about the things that matter. And wow.
Yeah.
How do you decide, I guess, when you're looking at all these patients, and like you said, there's so many mutations when you're dealing with exactly with what you're dealing with. How do you decide what tests are worth using, and especially when patients feel a little bit overwhelmed if cost is a factor in some cases?
Yeah, fortunately for us, the choice of test, we usually don't run into that big of an issue. I think at larger university centers, a lot of these tests are run in the institution itself. They have developed a CLIA-approved NGS platform that allows them to search for mutations. They do their own chromosome analysis in-house. They do the flow cytometry in-house, which also drills down into the immunophenotype of these leukemia cells. Where I currently work too, in my hospital sends the bone marrow biopsy results to the affiliated university hospital to do that testing. So that's generally not been an issue. As far as cost goes, we don't, because the tests that we run in the heme malignancy space are actually considered standard of care. If you don't do them, it's considered not adhering to the standard of care. We usually don't get too much pushback from insurance companies regarding cost. Sometimes, I don't know if that's the question you were asking, or whether
Yeah.
to know about these medications that we offer sometimes as a result of the results we get from the gene mutation testing.
Got it. No, you did answer the question, because it's a standard of care, and if you're not doing it, then it's not the standard of care. So that's great that actually, because well, in some cases, like, people do have to worry about the cost. It's crazy, like, because it's not necessarily something that's considered standard of care by insurance companies, but it's something that they may need. So what new approaches or technology in lab testing specifically do you think are noteworthy right now, that are happening right now, that you're most excited about, that can help you?
I don't have a lab per se, but there are other people who do like whole exome sequencing or transcriptomics that may potentially bleed, no pun intended, into the blood cancer space. I think we're still waiting to see how those are going to be used in prime time. I think in the heme malignancy space now, there is this topic of minimal or measurable residual disease testing, or MRD testing, which is another type of assessment that we can do as clinicians to determine whether or not somebody's cancer is really gone, because it's a very sensitive assay to determine whether or not there's any evidence of disease whatsoever beyond what can be seen with the naked eye. And so the MRD testing space was really well grounded in much of the work related to acute lymphoblastic leukemia, particularly pediatric acute lymphoblastic leukemia, where we learned as an oncology community that if a patient has even just a tiny bit of disease, that their outcomes are worse, that the cancer will definitely come back. And then this started to involve other types of cancers as well. How can you detect whether or not the cancer is really gone? So in the AML space especially, you could have somebody get diagnosed, get treated, you get their bone marrow biopsy at the end of treatment, and you don't see any evidence of leukemia. You don't see evidence of leukemia based on the flow cytometry results. If they had any chromosome abnormalities, those chromosome abnormalities have gone away. And then you also have their genetic testing, their NGS testing, that you can also use to determine whether or not their cancer has gone away. So so this topic of MRD testing has also come up in terms of how do we actually detect whether or not the cancer is gone. There are other platforms that use other technologies to search for MRD, particularly in chronic lymphocytic leukemia, the lymphomas, and multiple myeloma. So they will actually drill down into the exact clone that's abnormal and be able to track it over time, which is very interesting and has been very helpful for other types of hematologic malignancies, and can potentially help determine who's likely to relapse, and also provides a potential opportunity for early intervention in case it looks like somebody's cancer is coming back.
Wow. That's awesome, actually, to be able to tell that. So for the other practitioners that are listening, what advice would you give about integrating testing more effectively into their practice?
It's very critical that we do that. Cancer itself has gotten so complicated, and we know across a broad range of cancers now that everyone's disease is so unique. And I think it's amazing that we're able to really drill down into disease biology the way that we're able to do it. But I also think it's important to know which tests are relevant for your patient population at all stages of their care, at the time of diagnosis, at the completion of therapy, and in long-term follow-up. And for each cancer type, it's different. So understanding what is needed when is really critical. It's been a humbling experience for me where I currently work, because I was primarily a leukemia specialist when I was working at Ohio State, and now I work in a regional affiliate of an academic hospital at WVU, but I've had to expand my knowledge to other types of cancers, and it's been It's been interesting learning about particularly solid tumor malignancies and what kinds of tests we order for those patients at the time of diagnosis and on relapse. There's some similarities in the heme space, but there's also a lot of differences. So I would just say that it's important to know what to order and when.
Right.
Thankfully, we have a lot of tools. Like, you don't have to memorize this stuff either. There's a lot of tools that are available at our fingertips to help us with that ordering.
Okay. And how would you personally prioritize the types of tests you use that based on impact for your practice?
It really just depends on the cancer type,
Right.
but definitely it again, like, it just depends on the cancer type. So, if we're talking breast cancer, we want to know about the hormone expression, and we want to know about HER2 positivity up front, as well as other gene mutations that are potentially going to impact our treatment. And we're usually able to order those. We want to know about all of the molecular biology, particularly in patients who have metastatic disease. Metastatic solid tumor malignancies as well, I think, are really key, and something that we do up front on all of our patients through various NGS platforms. So I think at this point in time, this may very well change, and things change all the time in medicine, but I think at this point in time, it's really understanding the genomics of somebody's cancer, and then also in the solid tumor space, there's such a heavy emphasis on immunotherapy as well. So understanding somebody's PD-L1 expression and whether or not they might be responsive to the numerous immunotherapies that are now available on the market is also really key. But yes, all of that would be important.
Got it. And this one's more about like how you communicate with patients, but like, how do you explain the value of testing to your patients in a way that they really connect with?
Yeah, so it's actually pretty similar to what I said to you.
Yeah,
So,
figured. Yeah, right.
honestly, what we run into is, we have somebody with, let's just say, lung cancer in our office. And the patient and their family come by and see us, and they will say, well, I had a friend whose lung cancer was treated with a pill. Why are you offering me chemotherapy? And so,
Right.
sometimes it's important to, well, not sometimes, all the times, it's important to impress upon the patients that everybody's cancer is unique, and you could literally have a clinic that's full of patients that have lung cancer, and every single one of them could be on a different treatment, because the treatment is based on the histology of the tumor, whether or not there's certain genetic markers within the leukemia cells themselves. So at least when I'm explaining to patients, that's one thing that I say, and my patients hear me say this all the time, which is, not all cancers were created equal. And they weren't, in terms of how aggressive they are, in terms of how they behave, and in terms of how they're treated. And so, so I do explain that we want to get a better understanding of what their cancer looks like from a genetic standpoint, and what types of gene mutations the cancer cells might have gotten that could potentially guide treatment. And we don't get any pushback about it. They are open to it.
Makes sense.
They are often curious about the results, but more often than not, they just want to know whether or not any of those mutations have any implications for them in terms of therapy.
Got it. And if you could leave our listeners with one key takeaway about testing in patient care, what would that be?
I would say the most important, I'm sure you have a broad listenership, so I think it's really important to just arm yourself with the knowledge of the different testing platforms that you have available to you, and to make sure that they are done appropriately at the appropriate time points during a cancer patient's journey, because I've definitely seen the results of those tests make or break patients in terms of treatment options and ultimately survival.
Wow. All right. Well, Thank you so much for your insights today. I appreciate you sharing. How can we, for our listeners, how can we find you? Where can we find some of your work and what you're working on?
So, certainly I have a LinkedIn profile. Certainly my publications are also available on PubMed and Google Scholar if anyone's interested in knowing about the type of work I've done in the past. That's how you can find me. I have a Twitter account as well, but I hardly use it. Actually, I don't think I
Got
use
it. Ever since it became X, a lot of us stopped. No worries. All right. Well, thank you so much for joining us. Thank you guys for tuning in to the Better by the Numbers podcast. If you enjoyed today's episode, share it with a colleague or friend who's just medically curious. And don't forget to subscribe for more insights from doctors who are pushing care forward. And we'll see you on the next one. Thank you.
If you are interested in genetic testing, blood work panels, or other resources for your practice or business, check out lifemetrics.com.